Good evening, everyone. It's always a pleasure to be here in an event, and particularly with a lot more clinical colleagues. So the concept of molecular and immune factor consideration is a concept which we have been championing at NN. And before that, I have to say, I'm standing here on behalf of the entire NN team, both clinicians, clinician scientists, and scientists, who have been co-developing this concept for clinical utility, okay? And including a lot of patient volunteers. So this is the summary, okay? So we would want to enhance, obviously you already have post-op success rates. We want to enhance the rate further and the quality, and we want to support prediction and targeted therapy rather than after something which has happened. And this is the outline, and I'm going to concentrate on tissue response because surgeon's precision and technology is well taken care of. But beyond that, there is a tissue response which still remains to be conquered or even predicted and modulated by us. And that goes around with the ultrastructural changes, cellular functions, as well as the expression patterns which will influence the outcome. And as is the case in any surgery, a variety of things does happen. This is from a general surgical procedure in a laparotomy. And in a similar way, at an organ level, at an eye level, a similar set of reactions do happen after every procedure. And one thing is common is inflammation all along. And this is going to influence the immune privileged site or the status in the eye, thereby the ocular health as well as the post-operative outcome. These are concepts which has to be remembered for us to continuously develop this method. And one of the key things, in addition to other molecular factors we thought of, is the immune system, because the clinical community is well versed for more than 50 decades on how to monitor and modulate the immune system. And immune system influences a variety of both homeostasis and pathology. Therefore, we have chosen that. And it was over the last 8 to 10 years, we have systematically profiled what are the various immune components of the eye in health and disease, not only just the cytokines, which pretty much is done all over the world, and we have very few groups around the world have been looking at the immune cells in the different aspects of the eye, right from the ocular surface to the anterior chamber to the vitreous chamber as well. And we have been seeing very, very unique alterations which is worthy of being used as some kind of a prognosticating factors while standard of care is delivered well collection. Not only that, the important part of tissue homeostasis intertwined with the immune status, and there is a constant harmony between the ocular cells and the immune cells and the secreted immune factors. If you look at the textbook histopathology, we don't get to see immune cells. That's not what we're saying. We talk about the structural cells only. But these are intertwined and present all the time. And they bring about a perfect balance between the accelerator and the brakes, which make sure that there is an immune balance or even a homeostatic balance in the eye and on the surface as well. So we often talk about the jammed accelerator. What is going high is something which can be easily measured and can be easily targeted. At NN, we are also looking at what are the defective brakes? Can we put the brakes on in the endogenous systems? Okay, that's where the molecular consideration comes in. And a variety of factors and medical history is going to influence your surgical outcome, at least a molecular level. You can say some patients develop this, some patients don't. That depends on that kind of a regulatory balance, what kind of events they have been through, and whether that cataract surgery, which however perfect it was done, did it alter some amount of brake or accelerator inside, which just initiates a disease or triggers a progression of an existing disease, be it a retinal condition or like edema, like what Dr. Rudy was talking about. And why are we obsessed about the immune system? Because it forms the axis, the integrated network, and one of the key important factors which is the hormonal changes, because there is a very good regulation between the hormones and the immune system. Therefore, a good medical history along with a detailed hormonal information would help us predict the outcome. And why we are talking about the immunoinflammatory factors is that, be it wound healing, be it pain, or even any other ocular changes, despite a variety of unique factors which are going to alter these things which you see in the left, the factors in the middle. All of them are influenced by immunoinflammatory mediators, okay? So therefore, knowing them and modulating them is going to be useful, and prophylactically, it was going to be even better. And we can empower the natural regulators by making sure that they have sufficient vitamin D, omega fatty acids, and to an extent, diet. And of course, the clinical community is well aware of the post-operative medications and pre-op prophylactic care. But the important part is monitor them, catch them early, prophylactically treat them. You can definitely enhance the quality of success as well as the rate of success. And variety of pharmacological methods or options are available for individual alterations which you may see. Okay, but if you can monitor them, you will know which one to target rather than, of course, the clinical wisdom is always there to which pharmacological treatment is going to be effective, but you can always back it up with molecular information. And that took us in the last 4 or 5 years towards personalized clinical care. How are we going to do all patients receive the same kind of strategy? Can we stratify them? That's where molecular and immune consideration comes in, just like the genetics. And if genetics cannot be done on a routine basis, but molecular and immune monitoring can be done on a routine basis, as Dr. Shetty would have shown during the biomarker kits yesterday and today. We are able to stratify, we are able to find out which type of drugs would be more effective because we have backed it up with some of the experiments back in the lab. And I'm sure everybody is familiar about the kit which we have co-developed here. It's called the BioM Pathfinder kit, which has really enabled, empowered, and I'm sure that all the clinicians are enjoying using it because it is helping their treatment planning. And some examples before I wind up is in cataract surgery, we have been using using the tear fluid for pre and post-op monitoring, and as well as intraocular using the aqueous humor for predictive monitoring. One of the examples is if you look at the cataract patients, close to 40% and 60% or close to 16% of them do have discomfort, but if you look at the Schirmer's test and the TBUT, it is some of them do have low levels, meaning unfavorable, but that is backed up with increased inflammatory factors in these cases. And they have direct correlations with the clinical factors. Hence, it is necessary, all the red ones are the bad, higher levels in these patients. These patients, before you wheel them into the surgery, you can prophylactically manage them, dampen their, not completely inhibit, just dampen their inflammatory status before treatment. And you can clearly see, even if you forget the controls, in the cataract cases, those with and without Schirmer's test less than or greater than 10, you can see a substantial difference that clearly indicates the need for monitoring and prophylactic care. And some lessons from the aqueous humor is we were able to predict those, the VEGF levels were higher in those who went on to develop retinal pathology post-op. And what was unique was those with posterior subcapsular cataract had higher levels of VEGF. So these are all new information which is evolving, which is yet to get published, but it's going to change how we are going to see post-op care, and even in prediction. We can even see, like Dr. Rudy was talking about, whether these are the cases with high VEGF developing CME, cystoid macular edema post-op. And what was startling for us was, based on the type of cataracts, we are seeing a completely different immune cell profile in the anterior chamber. We wanted to see whether it is of any clinical relevance again. And some lessons from refractive surgery, Dr. Naren Shetty did show about this today. We were able to predict which patients can develop haze post-PRK, and this was something which Dr. Arko and Dr. Shetty was doing it, or when it gets published, I was just joining the lab. And what came about was this PREX1. We all are familiar with TGF-beta, right? But despite the TGF-beta, which is the protein structure, if PREX1 is present in large amounts, it can accentuate the process. And those patients whose intraop epithelium had higher PREX1 went on to develop haze, sorry, the black one, the haze predisposition. And the other part was pre-refractive surgery patients were categorized as controls for us, right, compared to dry eye and KC. But interestingly, what Arko and his team was able to do was, despite having normal levels of OSDI, TBUT, and Schirmer's, they still ended up having higher subclinical inflammation. So therefore, Dr. Rohit Shetty and others are doing prophylactic care before they get in for refractive surgery in order to enhance post-operative experience for the patients. Therefore, the integrated strategy, you can use molecular and immune monitoring for a variety of these depending on your needs. But definitely it's going to change how we are going to increase the success rate, the quality of success, as well as pave way to the industry towards targeted therapy. Thank you.
Thank you so much, sir. That was a wonderful presentation as always. Do we have any comments from the panelists?
Yeah, congratulations, great stuff.
Thank you.
I just wanted to sort of add a couple of things. In terms of PRK haze, in the same patient, if you change the ablation profile between the two eyes, you were doing the same correction, but you were changing the edge. In the first eye, unfortunately, we made the edge too steep, and that was a much more haze. And in the second eye, we made it much more shallow, and those eyes were very limited haze. And secondly, we were always able to switch off haze by using, as I explained earlier, mannose-6-phosphate, a simple sugar which bound to the keratocytes and just switched off the epithelial keratocyte interaction with TGF-beta.
Thank you. I've written it down and you said it in your talk, mannose-6-phosphate. Thank you.